Welcome guys. In this video we are going to discuss about this FMG recall of the medicine paper. We'll discuss first 10 questions in this set, and total around 40 to 50 questions were asked from the medicine part. We'll discuss one by one in the subsequent sets. So if you check the topic wise distribution, so majority of the question were asked from the CPS part, followed by the endocrine. Among endocrine, 50% were only from the diabetes, and rest around 5 to 6 questions from the infections. Almost all of the major topics of the Harrison has been covered in this FMG. Alright. So coming to the very first question. So it says about a 65-year-old male chronic smoker who presented with weight loss and evening rise of temperature, and chest X-ray is shown below, and what is the most likely diagnosis. So guys, when we have a history of chronic smoker who presented to weight loss and evening rise of temperature, two diseases should come in mind. One is tuberculosis and other being malignancy. Now, what are the hallmark chest X-ray finding in among of this? Now, usually in case of malignancy, this cannonball metastasis, which is referred to the multiple large oil circumcised round pulmonary metastasis are seen, as you can see here. All right. Okay. So, this cannonball metastasis are seen. These are classically secondary mainly due to renal cell carcinoma or choriocarcinoma, and it is very much common in choriocarcinoma that in other malignancy stage 4 is considered as metastasis, whereas in choriocarcinoma stage 3 is lung metastasis. Alright, it can be also seen in other less common primary tumor as well as prostate carcinoma and endometrial carcinoma. Okay, so answer here will be cannonball metastasis. Now if we check into the other options, what are the X-ray finding, guys? So in case of septic emboli, chest X-ray shows a non-specific finding. It usually involve peripheral lower lobe predominant infiltrate densities, which can be unilateral as well as bilateral, and diffuse bilateral nodular density, as you can see here. Diffuse bilateral nodular density can be seen of varying size, and one of the varying size. Why varying size? Due to repeated episode of embolic phenomena. Alright, repeated episode of embolic phenomena, and this size may increase or number change based on the subsequent follow-up radiographic imaging, based on how much the patient is improving as well as. Okay, sometimes completed pleural empyema may be seen also. Pleural empyema may be seen in septic cases also, and moreover there will be history of the sepsis present in it. Is there any history or suggestive of sepsis in this patient? No, it was a walking patient who came 65-year-old with weight loss. Alright. Now coming to the features of TB. TB features per se can be divided into two types based on the condition. It can be the primary TB, secondary or post-primary TB, or the miliary TB. Alright. Now, in case of primary TB, the initial focus of infection can be located anywhere within the lung and is very non-specific appearance. So, non-specific appearance include ranging from too small to be detectable, some chest X-ray radiographic changes, to patchy areas of consolidation, as you can see here. Patchy areas of consolidation, and usually one thing that should be remembered in case of primary TB, that cavitation is very rare. Alright, where is cavitation seen? Cavitation is seen in case of secondary TB only. Now, secondary TB or post-primary TB, or you can call it reactivation TB, which occurs usually years later of the primary TB, frequently in the setting of decreased immunity, or in the case of taking any medication which decreases the immune status. In the majority of the cases, post-primary TB within the lung develops either in the stool segment, either in the posterior segment of the upper lobe or superior segment of the lower lobe. So, and cavitation can be seen. You can see here in this image here. So, cavitation can be seen here in case of post-primary or secondary TB, and cavitation is the reason why behind presentation of hemoptysis in post-primary TB. Okay. Now coming to the miliary TB is uncommon and it carries a very poor prognosis compared to the other two, but it is seen. Why? It is seen mainly due to hematogenous spread of the TB bacilli, and when there is hematogenous spread, it can spread to anywhere from the main source. It can spread to the kidney, it can spread to the liver, and but easily detected in lung first, and appears to be as a miliary deposit, as you can see in the X-ray, miliary deposit, which are small 1 to 3 millimeter in diameter nodule, uniform in size and uniformly distributed. And if the treatment is successful, no residual abnormality is seen. So chest X-ray is a very good marker to check treatment responsiveness in miliary TB. All right. Okay. Now coming to the next option of the lung abscess. So was history suggestive of lung abscess? No, actually not. Lung abscess is a necrosis of the pulmonary tissue leading to the pus-filled cavity. As you can see here in the image, there is a pus-filled cavity with proper ER fluid level. Now lung abscess is usually single in nature. Here you can see multiple ER fluid level. When there is multiple lung abscess present, it is known as necrotizing pneumonia. It is known as necrotizing pneumonia. Or lung gangrene. Alright. Now, these multiple lung abscesses are very unusual and are due to septic thrombophlebitis or right-sided endocarditis, and usually in the setting of severe sepsis or in case of IV drug infusion. So, therefore, in our first question, the answer will be cannonball metastasis based on the history as well as the imaging. Now, coming to the next question. It says a 23-year-old male who presented in emergency with sudden onset shortness of breath and chest X-ray is given. Now in chest X-ray you can see there is increased lucency in the right side. So first of all, there is sharp outline of the right side of the lung compared to the left line. So there is sharp outline. One. Second point is absence of bronchovascular marking in it, and thirdly there is increased lucency along with presentation in ER with shortness of breath suggested towards pneumothorax. So answer here is pneumothorax case. Okay. Now coming to the third question, here it has been said about a 25-year-old male who after an incident of RTA presented in ER in dull and drowsy status. E first was done negative, no sign of visible bleed, heart rate is around 56, so heart rate is low, and BP is 88/60, which is again low. So patient came in a status of shock, and chest X-ray was done normal, ECG is normal, SpO2 93. We need to identify the type of shock. So shock, among the options given, septic, cardiogenic and hemorrhagic and neurogenic. So guys, what are the one important feature of each of this type of shock? So let's just divide it. Hemorrhagic, septic, cardiogenic and neurogenic. All right. Now, what happens in hemorrhage? When there is severe hemorrhage, there is decrease in effective circulatory volume, resulting in decrease in blood pressure and subsequent development of tachycardia. All right. Now, what will be the other feature? There will be, as there is decrease in blood pressure, decrease in effective circulatory volume, therefore there will be decrease in the urine output, and pulse will be weak in it. Tachycardia along with weak pulse. In septic, there will be known focus of infection, placid infection. There will be history of fever. Obviously, hypotension will be there along with tachycardia. So, decreased BP and increased heart rate will be present here. And skin will remain warm in case of septic shock. In case of cardiogenic, BP will be low, but heart rate depends on the condition of the cardiogenic shock. So, if it is due to cardiac tamponade or pericarditis sort of thing, or MI per se, heart rate can be increased. Whereas if there is heart block, any SN-nodal dysfunction, there can be development of bradycardia. All right. Okay. Along with other feature, there will be raised JBP based on the condition that is mainly involved. If this tamponade or pericardial effusion, severe pericardial effusion, there will be crackle zone auscultation, and obviously peripheries will be cold in it. Peripheries will remain cold. In case of neurogenic shock, what happens? In case of neurogenic, there is loss of sympathetic tone, resulting into bradycardia with hypotension. All right, bradycardia and hypotension, and peripheries will remain warm in case of neurogenic shock. So coming back to the question, if we check, so we have bradycardia along with hypotension. So when you have bradycardia and hypotension, there are two possibilities only, either cardiogenic due to heart block or neurogenic shock. Now if you see the ECG was quite normal, so cardiogenic is ruled out, and as well as chest X-ray was normal, there is no signs of cardiac tamponade or anything present. So obviously this is nothing but a neurogenic shock. Now one can argue that why it cannot be severe hemorrhagic shock, that there is no effective circulatory volume. So to have a severe hemorrhagic shock, there must be some source of bleed seen. So you can see there is no signs of visible blood in it. So if there is no signs of visible blood, what can be other source of blood? Blood can be in the compartment where we cannot see. So you can see E-first was done. E-first was also negative, and chest X-ray was no signs of hemorrhage was also present. So obviously hemorrhagic shock is ruled out in such cases. Therefore answer here is neurogenic shock. Coming to next question, it says, this is a little bit of tougher question compared to the level of FMG. So it is asking about organ which have more rejection after transplant. Now, if you check Harrison has mentioned about the 1 year survival rate of the post-transplant patient. Now, among the kidney transplant, if we check 1 year survival, in kidney transplant is 93 to 98%. In heart, it is 80%. For liver, it is 85 to 90%. And what happens in case of lung? In lung cases, 1 year survival is 1 year rejection is 50%. And among who receive rejection, that rejection that is within 1 year is 50%, and who doesn't receive rejection within next 5 years, 50% will receive rejection. So within total 5 years, more than 75% have rejection. All right. So organ which have maximum rejection is obviously lung. Now among the kidney, 93 and 90% is 1 year survival. You can check the reference here. So long-term management of lung transplant recipient, you can see that approximately 50% of lung transplant recipient will experience at least one episode of rejection in first post-transplant year, and by the 5 year post-transplant, approximately half will have developed chronic rejection. Now in liver transplantation, that 85 to 90% is the survival rate in 1 year, and 5 year is 60%. In heart transplantation, 1 year survival is 80%. In renal transplant, the survival is 93 to 98. 93% is for deceased donor transplant, whereas 98 is for living donor transplant. So among the solid organ, one which is maximum rejection is lung. Okay. So coming to next question, it says about the most common complication of ERCP. So what is ERCP, guys? ERCP is endoscopic retrograde cholangiopancreatography. It involves use of both upper GI endoscopy and use of the C-arm, that is chest X-ray, for visualization of the pancreatic and biliary duct for removal of any biliary stone. Okay, so it can be used for visualization of the ductal pathway as well as removal of pathology from it. Now, ASG guideline, American Society of Gastroenterology guideline, mentions about the complication or adverse event associated with ERCP. It clearly mentions that that overall incidence of post procedure pancreatitis is around 9.7%. The Rates of post sphincterectomy bleeding after ERCP is estimated to be 0.3 to somewhat around 2%, and cholangitis and sepsis, also known as adverse effect following ERCP, occurs around 0.5 to 3%, and duodenal rupture is very rare. So most common complication of ERCP is pancreatitis. However, if you check Harrison mentioned that it says about total risk to be around 5%. That is also very high. Okay. Now coming to this next question. So it says about a 35-year-old male who presented with difficulty in breathing and severe fatigue. On examination, distended neck vein was present, muffled heart sound. On auscultation, X-ray shown, identified the disease. So in X-ray, you can see the globular enlargement of the cardiac shadow. Okay, this globular enlargement gives a water bottle appearance. Which is specific radiographic imaging finding of pericardial effusion. Now, whether this pericardial effusion is amounting to cardiac tamponade or not is based on the presence of backstride. So, what is backstride, right? Backstride is nothing but clinical triad with features of hypotension, muffled heart sound, and distension of JBP. Alright. So this, if along with presence of other feature of pericardial effusion, is suggestive of cardiac tamponade. So as you can see in our history, there is neck vein was distended, muffled heart sound was present, and JBP was elevated. So it is obviously cardiac tamponade. Now investigation of choice is obviously 2D echo in such cases to identify the pericardial effusion, as chest X-ray is not so much sensitive, neither specific. ECG will give electrical alternates, and treatment will involve pericardiocentesis. Okay, so we have backstride of hypotension, jugular venous distension, muffled heart sound, ECG of electrical alternates, and pericardial effusion in 2D echo. Now coming to the JBP finding, which has been mentioned here, JBP has mentioned to be shown to be absent Y descent. So why it is seen? Now JBP, there are A wave, C wave, V wave, X and Y descent. So A is due to the atrial constriction, C is due to isovolemic constriction, V is ventricular constriction, X descent is the active filling ventricle, and Y is the passive filling of flow of blood from atria to ventricle. Now what happens in cardiac tamponade? It does not allow the ventricle to expand. So ventricle cannot fill properly, resulting into blunted Y descent. Okay. Alright. Now coming to the next question, it says about the MAN1 disease and its association. So it has been asked multiple times in this exam. So you can remember MAN1 with the mnemonic Peter Pan. Also spelling is different to remember, so you remember it to Peter Pan. So we need to know about MAN1, MAN2A and MAN2B. Alright, so MAN1 is Peter Pan. Peter means here pituitary adenoma. Then R for R is parathyroid hyperplasia or adenoma. So parathyroid hyperplasia, pituitary adenoma, and PAN is pancreatic tumor. In case of MAN2A, there is parathyroid hyperplasia as well as pheochromocytoma present. So parathyroid hyperplasia is common in them, but additionally we will have pheochromocytoma pheochromocytoma, and medullary thyroid carcinoma. Medullary thyroid carcinoma and pheochromocytoma is again common in men 2B, along with presence of mucosal neurofibroma and Marfanoid habitus. Alright. Okay. So answer here will be pheochromocytoma. No, it is absent. Renal cell carcinoma is absent. Medullary thyroid carcinoma is absent. Answer here is parathyroid adenoma. Okay. So again here, so we have got MEN1 pituitary adenoma, parathyroid hyperplasia, pancreatic tumor. It can be remembered by mnemonic PET or PEN. Alright. PET or PEN. Now coming to the next question, it is asking about contraindication for use of BiPAP. Now BiPAP is bilevel positive airway pressure. So this is a form of non-invasive ventilation. This is nothing but a form of non-invasive ventilation. So what will be the contraindication for use of BiPAP? Contraindication for use of BiPAP will be indication for invasive ventilation. So when we cannot keep the patient in non-invasive ventilation, if there is risk of inability to protect the airway, such as there is any sort of facial trauma, post-surgery, there is risk of upper airway compromise, difficulty clearing respiratory secretion, there is high risk of aspiration, or there is severe upper GI bleed or severe encephalopathy, or severe vomiting or upper GI bleed, vomiting or severe upper GI bleed, it's better to intubate the patient, obviously. So you can see here, unconscious state, there is obviously risk of airway not to get protected. Therefore, in such cases, invasive ventilation will be required. BiPAP will be contraindicated. So here you can see this bilevel positive airway pressure machine, in which inhale pressure and exhale pressure both are given through this machine, and marks is given to the patient. Now, common contraindication of non-invasive involve high risk of aspiration, inability to protect the airway. So when the airway cannot be protected, if the patient is unconscious or sedated. Now coming to the next question, it is asking about the Ritter syndrome and its association. So here HLA-B51 is associated with Behçet disease. HLA-B27 is associated with Ritters. What is Ritter? Ritters is nothing but the reactive arthritis. So association of HLA-B27 can be remembered with the mnemonic ER. So A for axial spondyloarthropathy, I for inflammatory bowel disease, and R is reactive arthritis. All right. Axial spondyloarthropathy includes ankylosing spondylitis, angspont, juvenile arthropathy, and psoriatic arthritis. All right. Okay. So here you can see HLA-B27 in axial spondyloarthropathy, inflammatory bowel disease, and reactive arthritis. Remember it to be ER. Okay, so reactive arthritis is associated with the HLA-B27. Coming to the next question. So here 60-year-old man with history of diabetes mellitus present with fever, night sweat, and white loss. 2D echo revealed vegetation. To diagnose To diagnose infective endocarditis, how many blood culture is necessary? So ideally, to diagnose infective endocarditis, we need 3 sets of blood culture. Both aerobic and anaerobic sets are required. Both aerobic and anaerobic sets are required, and it should be collected from the different site for diagnosing. So if you look at the criteria, Duke's criteria, that is modified Duke's criteria for diagnosis of infective endocarditis. So we have major criteria and minor criteria. Major criteria involve blood culture. So major, and we have minor criteria. Major involves blood culture and evidence of endocardial involvement. So it's from echocardiography imaging, which is suggestive of vegetation. All right. For the minor criteria, we need the following thing. We need temperature more than 38 degree Fahrenheit, 38.5 degree Fahrenheit. We need the immunological phenomena, the embolic phenomena like rot spot, Osler node, and everything. And we need microbiological evidence. If blood culture positive, all these cultures are not positive, then only microbiological evidence not fulfilling the criteria by the presence of one single blood culture positive or serology positive, of which difficult to get blood culture positivity, and presence of risk factor like IV tract user or tricuspid valve involvement. So this is the major and minor criteria. You can look again here. So we have major criteria: positive blood culture or evidence of endocardial involvement. Positive blood culture, we need minimum of 3, all or 3 or majority of 4 separate blood culture required. And for minor criteria, we need predisposing heart condition, fever, vascular phenomena like granulations, intracranial hemorrhage, mycotic aneurysm, septic pulmonary infarct, or immunological phenomena like Osler node, rot spot, rheumatoid factor. Microbiological evidence with positive blood culture not meeting the major criteria, or serological evidence. Now you can see the thing about the blood culture, that is 3 blood culture set is required. 3 blood culture set required. If patient is stable, usually it is better to keep 3 blood culture set only. And if we are suspecting organism to be something which is not readily culturable, so non-blood culture test for difficult to recover organism for brucellosis, Treponema whippley, Coxiella baineti, and Bartonella. These are the difficult to culture organism and known to cause infective endocarditis. In such cases, serological testing can be done. Okay, so you can see here in the Harrison itself. So it says 2 bottle blood culture set is required containing the appropriate volume of blood, that is 10 ml per bottle. 10 ml per bottle should be taken for the diagnosis. And if there is difficult to culture, we need for like Brucella, Bartonella, Treponema whippley, or Coxiella baineti, then we can go for serologic test. Okay, all right.